Hey guys, can you see me? Can you hear me? Hello everyone. A very good evening. It's been some time for the RRR series. So this will be the last lecture in the first chapter, and then we will have a entire day. That's the next RRR. We'll discuss questions. Right? I want to kind of cover like 20-25 questions the next RRR. So today we are going to just talk about apoptosis. We had missed this thing initially, so I'll try to cover apoptosis. Can you guys hear me? Can you guys listen to me? If so, say me a hi and a hello. Very good evening. Okay, so we do know about necrosis, we know about cellular injuries, reversible, irreversible, intracellular accumulation, calcification, everything, right? So, good evening, Anita. So, in that note, we'll start discussing about apoptosis, right? Great. So, you must have read about apoptosis. It's not apoptosis, it's apoptosis, right? It's apoptosis, two different words, right? So, ptosis here means it's drooping or falling, right? That's what literally ptosis means, is drooping or falling. Apo is precursor. So apoptosis means whatever happens just before a cell's fall or cell death is called as an apoptosis. It's very, very structured and is very, very programmed, right? It's extremely programmed form of death, which means it's perfectly under DNA's control. It's perfectly modified by DNA, genes, positive control, negative control, feedback mechanism, and everything, right? And it plays critical role in both physiological and pathological conditions of cell death, right? So every cell death, if it's pathological, it is most likely to be apoptosis or necrosis, right? If it's physiological, it's only apoptosis. Remember this: necrosis can never be physiological. Necrosis is almost always pathological, and apoptosis can be both physiological and pathological, right? We'll see that why very soon in the latter part of the discussion. Fine. Sure, Lalit. Okay, you tell me, like, you ask me what is doubt, then I'll definitely discuss that aram se. Okay. Fine. Now let's look at two different types. So we do know about physiological apoptosis and pathological apoptosis, right? Can anyone tell me or give me examples where physiological cell death can happen? Any one example where physiologically a normal person's cells will die? Anything which comes to your mind? Anything? Bio Baba, good evening. Hello, good evening. Physiological cell death, there are lots and lots and lots of examples in during embryology, right? Embryological examples are huge. There are many things what we have, we don't have now, right? Skin cells, like Baba said, that also is a physiological example of cell death. Every day my skin cell dies, GIT dies, right? Embryological remnants, the thyroglossal tract, your notochordal remnants, right? The thymus. In adults, we don't have that, right? Although it's not embryology, it's an evolution, right? It's an when physiological death or all this will come under that, right? Notochord, which is disappear, right? Perfect. So you have the thyroglossal duct or thyroglossal tract. Fine. So there are many things in embryology which will come under physiological apoptosis, right? If you remember, when we were in the embryo, all the fingers were united. Tell me what question in tumors, Lalit. Please give me a question rather than asking me aram se boliye, ask question. Fine, I'll definitely answer that. Right? So when we were in the in utero, all these fingers were united. So all these webs kind of destroyed and we had individual fingers. Now I'm going to ask you a simple question. I want you guys to answer. Let's say this embryological apoptosis failed, right? This embryological apoptosis failed. Fine. Tell me, will the fingers divide as two or they'll stay as the same finger? There's a failure of embryological apoptosis. They will be united, right? Have you seen anyone, not in the hospital, in real life, where two fingers are united? You might have seen, right? As an example of failure of physiological apoptosis, right? We call that syndactyly. Syn means united, dactyly is fingers, right? I'm sure you must have seen them, right? So you don't want a hospital to see patients, just what your brain knows, your eyes will definitely see them, right? So that's an example of embryological apoptosis and deviation from normal embryological apoptosis, right? Perfect. So then, as you guys said, that skin, the epithelial regeneration. I'm not taking about only skin, your GIT, everything, right? Skin, GIT, everything kind of dies over the period of time routinely, not just normal epithelium, your uterine epithelium, right? Dies physiologically with every menstrual cycle. There are lots of physiological examples of apoptosis also, fine. Okay, okay, great. So then we have few things like post-inflammatory cells, okay? Post-inflammation, there are cells which should be like, let's say I have 10 bacteria. For that 20 WBCs came, killed all the bacteria, but there are 3-4 WBCs not utilized. They will not go back into the bloodstream. It's very difficult for them to go back to the bloodstream, and they will die by default in apoptosis, right? In other words, have you read about thymus, an organ called as thymus, in your first year? Can anyone tell me what's the function of thymus? Whatever comes to your mind. You may be right or wrong, doesn't matter. What do you think is the function of thymus? Thymus kind of teaches the T cells, right? So thymus has something called positive selection and negative selection. Thymus will kind of remove all these self-reacting T cells. That's the main function of thymus, right? Biobaba, immunity is a very broad terminology. Thymus kind of teaches my T cells to become more mature and to remove all self-reacting T cells. I'm just giving a random example. I have a T lymphocyte which is thinking my skin has foreign. Should the T cells remain in the body or they should die? What do you think? T cells will remain in the body or they should die? They should die, because if the T cells remains, my skin will be considered foreign and will have autoimmune reactions to that, right? So these are called as self-reacting T cells. The self-reacting T cells will be by default removed, because if they are not removed by thymus, you will end up in having autoimmune reaction, right? All these are physiological examples of apoptosis. Any physiological cell death which comes to your mind, you can put that here, because physiologically cell can die only by apoptosis and never by necrosis, right? Now let's go to pathological type of cell death, right? Pathologically, there are 3 instances where a cell dies by apoptosis. One is obviously DNA mutation. Whenever there's a mutation in the cell, if I am not able to correct the mutation, the cell will die by apoptosis, right? Second is viral infection. Any viral infection, one of the mode of cell death is by apoptosis, right? Third, and the most important thing, intracellular protein accumulation. So whenever I have lots of cells, right, lots and lots of protein accumulating inside a cell, I am not able to destroy it, it will end up in apoptosis, fine, right? Intracellular protein accumulation. If my body or the cell is not able to kind of regulate the protein accumulation, not able to remove them, abnormal proteins, all of them will end up in having apoptosis by default, right? This is the most common trigger for apoptosis, DNA mutation. Then comes your viral. Intracellular protein accumulation also plays a major role, right? These are the 3 major pathological instances where apoptosis will be triggered, right? Now, let's have a quick overview of apoptosis, and then we'll see what exactly happens, right? So when you look at the mechanism of apoptosis, have you read about your coagulation cascade in your first year? Extrinsic pathway of coagulation, intrinsic pathway of coagulation, and both of them will join in the common pathway, right? You must have read the Y-shaped structure in your Guyton genome. You must have, right? Similar way, I have something called as an apoptosis. I have an extrinsic pathway, I have an intrinsic pathway, and both of them will culminate in an execution pathway. I don't have a common pathway here. We call it an execution. Execution phase is definitely common, right? So what happens here is, I do have 2 things here. We call this an initiator phase. Okay, this is starting point, right? This initiation can be in 2 forms. One, it can be extrinsic. Extrinsic means, see, I am talking about a cell. What is the external part of a cell? If I have a cell, what's the outer surface of a cell? It is cell membrane, right? So extrinsic pathway is also called as cell membrane mediated. Something from the cell membrane is going to trigger that. So it's cell membrane mediated. The other one is intrinsic, which means the trigger here comes from inside the cell, right? So inside here should be organelles, and one of the organelles which can trigger apoptosis, mitochondria, right? So I can have the initiator pathway in 2 types. Either it can trigger from a membrane or it can trigger from mitochondria. Whatever may be the trigger, it will come out in a common pathway only. The common pathway or the execution phase will be the same, right? Then it will go to an execution phase. This execution phase is common for both, same like your coagulation cascade. Its common pathway is execution phase. This will automatically cause apoptosis or the cell death. Okay, that's what we're going to read. What is the extrinsic pathway, what is intrinsic pathway, how they are triggered, and how the cell is going to die is what we're going to read in the next 25 minutes. Fine. Okay, let's see. Let's go one by one, step by step. Extrinsic, then intrinsic, then execution. So before going to extrinsic and intrinsic, I want you to understand what does normal cell have. If I know normal, abnormality is a piece of cake, right? Now in the extrinsic pathway, let's see a normal cell's cell membrane, which means my skin cell, my GI, every cell's membrane will have something which is very common, right? So if you take any cell, okay, let's assume there's a nucleus, this is a cell. The cell's membrane has a receptor called as FAS. Okay, this is a receptor which is present in your cell membrane, my cell membrane, all the body. I have a FAS receptor, right? These are many other names. CD95 is one more name for it. It is a type of TNF superfamily of receptor. It's a type of TNF receptor, right? This is there in a normal cell. Will be there in any cell in my body. Even if it's abnormal, I'll have it. We'll see what will be the change here, right? So let's assume a person has a viral infection. Okay, let's assume I have a sore throat. So what happens, like if it's a virus, which cell should offer immunity? If it's a virus, which cell should offer immunity? Which cell should offer immunity? Lymphocytes, right? Any viral disorder will be taken care of by the T lymphocytes is perfect. Lymphocytes is also an easier one, right? Perfect. CD8 T cells is an absolutely right answer, right? Now let's say I have the same cell, the normal cell. This is getting infected by a virus. I'm just writing virus here for an example, just to understand this is a virus infected cell, right? Can I say this virus infected cell will also have the FAS receptor? Is that right? They'll have the FAS receptor. It will not go anywhere because the receptor will be there in the cell. Till the cell lives, they'll have the receptor, right? Now what happens is, I have a T lymphocyte coming here. Like you guys said, CD8 T cells is coming here, fine. I'm not able to understand a question by Baba. Innate immunity is the first line of defense, right? Okay, when a T lymphocyte comes inside, I won't call it an innate immunity. It comes to adaptive, right? T cells and B cells are components of adaptive immunity. We'll read them when you go to immunity chapter, fine. Okay, let's come back to this. So my Hindi is sort of weak, so and my process of Hindi is very slow in my brain. So I'll try to explain in English. Any doubt ना आप हिंदी से पूछो, मैं इंग्लिश अंग्रेजी और हिंदी मिक्स करके रिप्लाई डालना, ठीक है? Fine, fine. So I have CD8. So CD8, what happens is I have a cell which is infected with the virus, and this has the FAS receptor, right? This CD8 will definitely come and will join here. And this CD8 will have something called an FAS ligand. TQ, so it's not a problem. If it's in BioBaba, English is not a problem at all. Let's learn pathology. That's more than enough, right? Because patients are going to be in your mother tongue. That's more than enough, right? Okay. So this CD8 will have the FAS ligand. Can a ligand bind to a receptor? They can, right? So CD8 has an FAS ligand and the FAS receptor is on the cell, right? So now what happens is this will happen only when there's a virus. If there's no virus, CD8 will not come and interact at all, right? So now FAS ligand has bound to the FAS receptor. I'm writing R for us to understand it's an FAS receptor. Once the ligand and the receptor binds, automatically it will trigger the downstream pathway called as FADD. This is a transcription pathway. If you remember physiology, any receptor binds with a growth factor or a ligand, the downstream transcription signals will get activated. That's your FADD. FADD stands for FAS, A for associated. I'm going to kill the cell. So DD for death domain. Okay. So this is what will happen in the extrinsic pathway. FADD will be activated. So what this FADD primarily does is, there's only one role for FADD. They'll convert an enzyme called as procaspase. It could be 8 or 10 to caspase, active caspase 8 or 10. Similar to your coagulation cascade, converting an inactive protein to an active protein. That's the job of FADD, right? So let's stop here with the extrinsic pathway. We will see what will happen to intrinsic pathway, and then we'll come to the common pathway, right? Just I'm going to write on the top. In the extrinsic pathway, what we will have is caspase 8 or caspase 10. Similar to a coagulation cascade, we have multiple things. So here in extrinsic pathway, at the end of it, if it's successful, I'll have either caspase 8 or caspase 10. 10 is for human beings, 8 is something which is understood in lower animals, fine? Okay, let's go to this. Let's go to intrinsic or mitochondria. Okay, so intrinsically something is happening inside the cell, which is mitochondrial. Again, there are few basic things which I want you to remember. Once you know the normal, abnormality is very easy, right? Great, Soha. Soha, you teach me Hindi next year. No, I'll try to teach in Hindi. Fine. Okay. Now let's go to basic things of genes and proteins and its location. Gene will be in the nucleus only. All these proteins are located in the outer mitochondrial membrane. Okay. They are present in the outer mitochondrial membrane, and all these proteins are called as BH proteins, right? So BH stands for a few domains, that's all, right? So what, like if you take some proteins, have you heard about thioester bonds in your biochemistry? You must have read about thioester bonds, right? So there are multiple proteins in our body which I determine with the help of few bonds, double bond, single bond, bond between two molecules with this amino acid and all those things, right? Like that, I have a bond or a group of protein called as BH, right? So this BH is a domain. Okay, so based on the presence of BH domain, actually that's how I categorize this protein. Though the function is different, but the basic categorization is based on the BH domain, right? I gave an example of thioester. This is not thioester, this is something like that, right? So BH domain, based on that, if a protein has 4 BH domains, that is 1, 2, 3, and 4, all the proteins with 4 BH domain will act as anti-apoptotic proteins. Anti means will stop apoptosis, right? All the proteins with 1, 2, and 3 BH domains, they'll act as pro-apoptotic, which means they will promote apoptosis. Something will have only BH3, only BH, third BH alone, then they'll act as sensors of cell stress, right? So these are 3 groups of proteins. These are one-liners. You have to memorize them, unfortunately, right? I'm just going to ask you a question for us, maybe a way to remember this. If a protein is anti-apoptotic, what do you think will happen to the lifespan of the protein? Will it be more or less? So the lifespan of the cell will be more or less. Lifespan will be longer, right? By default, if it's anti-apoptotic, going to stop the apoptosis is going to be very long or a very more lifespan, right? Perfect. So whenever it's anti-apoptotic, you guys only said it'll have a very long life. So remember something with L, I'm going to call them as long life or anti-apoptotic. Just a clue. The problem with clues are it will bite our back. BCLXS. Remember, it's small. Okay, this is pro-apoptotic. That's an exception, fine. Cancer is a disease, right? We are talking about normal thing, how a cell dies. In cancer, you tell me, what do you think will happen in cancer? Will apoptosis happen or will not happen? It's a cancer. The problem with cancer is uncontrolled cell division. What will happen? Apoptosis will not happen, right? Remember this. When we read neoplasia, we'll definitely apply that. Your thought process is right, but here we'll read about normal apoptosis. We'll talk about cancer when you come to it, right? That's all perfect. Okay. So this is an exception. BCL-XS is small, but this is not actually an important protein. The only thing what is required for us is BAX and BAC. These are two pro-apoptotic proteins. There are many anti-apoptotic proteins. These 3 at least remember: BCL2, BCL-XL, and MCL1. Remember, right? And sensors are BIM, BID, Puma, Noxa. These are again normal proteins in a cell. Let's understand same way what we did for extrinsic. What will happen to a normal living cell, and then we will understand what will happen when there's an apoptosis, right? A normal living cell, let's assume that this is a mitochondria. It's not a very good mitochondria, so bear with me. Okay, I hope it will at least do the ATP function, right? So let's assume this is a normal mitochondria. In this mitochondria, like I said, where will the proteins be? Outer membrane or inner membrane? Outer or inner? Outer, right? So again, I'm talking about a normal living cell. A normal living cell should not die. So which means they will have anti-apoptotic protein. They'll have BCL2 here. Okay. So BCL2 will be present in a cell which has to live for a long, which will not die for a long, right? So I have BCL2 here. So once I have BCL2, the job is very simple. BCL2 function is a very good question, Sunny. See, most of the cells will have a limited lifespan, right? So what happens is when you take neurons and when you take cardiac myocyte, they never function alone, right? Since Sunny asked this question and deviating from the normal, let's say I have a skeletal muscle, I have a cardiac muscle, I have a neuron. Can I say all these three function as a unit? Is that statement right? You never learn a muscle fiber. I learn muscle. Muscle functions as a unit. Cardiac, skeletal, or my neuron. Neuron functions as a unit, right? Now tell me, I have a single cell in my skin. A single cell, when I hit it, there's very likely chance it will die, right? Just an example. But when I'm a unit, when any force comes, be it physical, be it mechanical, be it chemical, thermal, something, can I say they can resist for a longer time? They can resist for a longer time, right? It's not that they have more anti-apoptotic protein, they're definitely more long-lived, they're definitely more sustainable in terms of the act as unit. So BCL2 will be there. But if the normal CNS or normal cardiac protein or your normal skeletal muscle has a damage, it will definitely die. I cannot stop it. If I'm going to cut the muscle, it will die by default. I cannot stop, right? But in general, since they function as a unit, they have a little bit of more longevity than the others. Fine, perfect, Sova. Right, let's come back to this. So normal living cell have BCL2. BCL2's function is only one. It's going to stop the exit of cytochrome C. Okay, let's stop the exit of cytochrome C, right? Can anyone tell me what's the function of cytochrome C from your first year from BBS? Cytochrome C helps in electron transport chain, helps in the production of ATP, right? That's the function of cytochrome C, right? Now, if a cell has to live, the cytochrome C should be there inside the mitochondria and not outside the mitochondria, right? So by preventing the exit of cytochrome C, they make sure cytochrome C stays inside mitochondria. So when they stay inside the mitochondria, obviously electron transport chain will be normal, which means ATP production will be normal, which means indirectly the cell is going to live for a longer time. That's all. That's a living cell. A living cell requires ATP. This is how it is done, right? Now let's see what will happen when the cell has an insult. In other words, a DNA mutation, right? There's some error which I'm not able to correct, right? Can I say this error is a stress to the cell? Is the statement right? Definitely it is right, right? Right, it's a stress to a cell. Whenever there's a stress to a cell, who will identify them? Sensors of cell stress, right? So this will be picked up by my sensors. This will increase the sensors. The sensors are your BIM, BIT, BAT, PUMA, NAXA, right? Any of them, I'm just writing BIM, BAT, anything. All the five will contribute at some point of time, right? Hypothetical, right? So whenever there is very high amount of sensors, what they do is they actually do two things. One, they will destroy BCL2. BCL2 is like a watchman for cytochrome C. They'll destroy them, right? Next, they will promote Baxan back. They'll increase the expression of Baxan back and they'll destroy BCL2, right? So Baxan back is exact opposite of BCL2. That's what they do, right? Baxan back is going to promote or increase the exit of proteins from your mitochondria. Okay, there are multiple proteins. Actually, two groups are very important for me. We'll talk about both. I'm sure you know one protein. What is the protein which was blocked by BCL2? Cytochrome C, right? So what they do is they primarily increase the exit of cytochrome C into cytoplasm. So cytochrome C leaks into cytoplasm. If it leaks into cytoplasm, my ATP synthesis will slowly reduce. The cell is going to slowly become dysfunctional. Not just that, the exit of cytochrome C will trigger another mechanism also, right? Here the death is not by losing the mitochondria. Here the death is by increasing the cytochrome C in cytoplasm. That has a trigger of events, right? So when cytochrome C goes into cytoplasm, this binds to one more protein called as APAF. APF1. APF stands for apoptosis, AF for activating factor, right? It's apoptosis activating factor. So when apoptosis activating factor binds to cytochrome C, this will form a complex called as apoptosome. Okay, there are few things which I want you to remember till you read medicine. One is like when we read necrosis, I have told you to remember this. What do you mean by oid? Oid means we read them in fibrinoid necrosis. What do you mean by oid? Oid means like, perfect, right? Like that, whenever anything ends with som, right? Whenever anything in medicine ends with som, it's not a single protein, it's a combination of proteins. Lysosome, one enzyme or many enzymes? Many enzymes, which means many proteins, right? Inflammasome, many proteins. It's a combination of proteins, not a single protein. Remember that, right? Anything which ends with "-some" is going to be multiple proteins together in a single structure, not a single protein, right? So what apoptosome does is same thing what FADD did for me, right? Apoptosome is going to convert your procaspase. What is the procaspase in extrinsic pathway? Numbers 8 and 10, right? But here they'll convert procaspase 9 to active caspase 9. I'll convert procaspase 9 to active caspase 9 here. That's what apoptosome does, right? This is the primary mechanism, right? Sanchita, my lectures will be a little bit more in English, right? Then when I have an exit of proteins, one more group of proteins also come outside. That's called as SMAC and Diablo. Okay, so what will SMAC and Diablo do is SMAC and Diablo will bind to one more group of proteins to inactivate them, right? Now, can I say apoptosis is something which is very important for us, right? A cell's death is very, very important, right? It's very crucial. So always I'll have both positive feedback and negative feedback in place. Whatever is important for me, it's very tightly regulated, right? So for a normal living cell, first regulation comes from here, BCL2. Okay, I'm just giving a very random example. Listen to me carefully and answer. I'm going to punch myself, punch like this. Is there any possibility the force can slightly damage mitochondria? Just a random example. Can it? If it happens, is there a possibility, even if BCL2 is there, some amount of cytochrome C can leak outside? It can, right? So if some amount of cytochrome C leaks outside, just for an example, SOVA, which will not happen in real life, just for an example, right? If there's some amount of cytochrome C which is coming outside, I need someone to stop that, right? Because only when it crosses the threshold, I need to activate them. I cannot keep on activating every time, so that cell will die, right? So I have a person who's normally going to inhibit apoptosis, which is there in cytoplasm, right? We call them IAPs. IAP stands for inhibitors of apoptosis. Okay, it's inhibitors of apoptosis, that's all. So the normal role of IAP is to stop apoptosis if they are triggered by an error. Might happen, just a check mechanism, that's all, right? So if it's triggered by an error, it'll be there. But now tell me, is this by mistake triggering, or I need to kill the cell here? I need to kill, right? Because there's an error, mutation, I need to kill by default, right? So what SMAC and Diablo does is, SMAC and Diablo will bind to your IAPs, inhibitors of apoptosis, and they will destroy them. That's all, right? So once they destroy, can I say there is no checkpoint for me to kill the cell? Everything is taken care of, right? So there are two things I'll repeat. Exit of proteins, there are two things. One is most important for me, cytochrome C. Cytochrome C comes outside, binds with APAP1, forms apoptosome, which activates caspase. That's the most important thing. At the same time, I have one more group of protein called SMAC and Diablo, which comes and destroys the inhibitors of apoptosis so that apoptosis flows smoothly, right? Let's go back to our first page again. Let's write here. I've got here caspase 9. So either caspase 8 or 10 will be activated, or caspase 9 will be activated by extrinsic and intrinsic respectively, right? So now the trigger for common pathway is very simple. It's either of these, that's all. Sorry. It's either of these. When either of these comes into play, I will be able to trigger the extrinsic pathway or the execution phase, right? Now, if I have either Cas8, Cas9 or Cas10, either of them will be enough for me to trigger the execution phase. So in execution phase, again, I have two important enzyme activation, which is caspase 3 and 6, and one more protein called as an endonuclease. Okay, if you remember necrosis, did we read necrosis also as enzyme activation in the last when calcium comes into play? Yes, right? They also had enzyme activation in the last, right? So the only difference is between caspase endonuclease, there's one more enzyme which was activated in necrosis, which was phospholipase. In necrosis, we read phospholipase, caspase, endonuclease, and what is lacking here is phospholipase. So can I say in apoptosis, the cell membrane will not be damaged because there is no phospholipase, right? That's a main difference between necrosis and apoptosis, right? Caspase is nothing but a protease. It's a modified protease, that's all, right? Endonuclease, I am sure you must have read in biochemistry again, restriction endonucleases. They cut at palindromic site, right? It's an endonuclease, that's all, right? Now, let's take a cell. Have a cell like this, okay? This cell is being acted upon by caspase and is being acted upon by endonuclease, okay? Fine. How do I destroy a protein? When I destroy any protein, will the protein kind of condense and become a precipitate? Is that statement right? Definitely, right? So if a protein is destroyed, if the protein becomes precipitate, they will definitely precipitate proteins. If a precipitate is happening, it will be bigger than the original protein or smaller than the original protein. It's a protein precipitate. It'll be smaller than the original protein, right? Exactly like an EcoR1, it's a restriction endonuclease, right? So here, the cell per se will become smaller. Because it's a destroyed protein, it's a precipitate, the cell will become smaller. If you remember your necrosis, can I say in necrosis we had cell swelling? Yes, here cells will shrink. Cells will not swell, the cells shrink. That's the first and the most important point, right? Next, the DNA. The DNA here, normally we have something called a new chromatin, which is open chromatin. Here, it's a restriction endonuclease. They will cut the chromatin, right? So what happens is they will cut the chromatin, or in other words, they cause chromatin condensation. Okay, I can actually call this pycnosis, but the term is not used here, but it's chromatin condensation or DNA damage, that's all, right? If you remember necrosis, I told the hallmark of necrosis is cell membrane damage. Can you guys tell me what is the hallmark of apoptosis? Protein destruction or DNA destruction? Which you think is more solid for me to say the cell is dying? Undoubtedly DNA destruction, right? By default, chromatin condensation is the hallmark for apoptosis. If a question is asked, this is the hallmark of apoptosis, because protein damage, I cannot call it as a hallmark of apoptosis. I can produce a new protein if the DNA is normal, right? Hallmark of necrosis, cell membrane damage. Hallmark of apoptosis, your chromatin condensation, right? Now let's see what will happen to this tiny cell, right? So this tiny thing is called as an apoptotic body. So apoptotic body is the final thing what will be there at the end of apoptosis. This will be smaller than the normal cell. It will be darker cytoplasm than the normal cell and have a small and condensed nucleus. Okay, it may have nucleus, it may not have nucleus. This is plus or minus, but it will be smaller, it will be darker pink, right? Now tell me, should this apoptotic body be removed or it should stay there forever? What is your take? Should they be removed or not? By default, they should be removed, right? Apoptotic body has to be removed. Who's the cell which removes every dead particle in my body? Phagocytosis happens by most of the time by macrophage. Macrophage eats every cell debris, right? So now here, this apoptotic body should be removed, and obviously the guy who will remove it is macrophage. Okay, macrophage has to remove it. Fine. Can I say, am I right in saying that for a macrophage to function, should it be opsonized? Have you heard the term opsonization? You might have. Yes, opsonization is nothing but it should be coated with something which makes them tasty for the macrophage, and only then they'll eat it, because macrophage will not eat every cell. only when it's opsonized, right? So for my macrophage to remove these cells, I need something which I'm going to call them an eat me signals. Generally, the eat me signals for a bacteria, for a fungi, everything is your cytokines, interleukins, complement proteins, that, right? But here I have a different eat me signal. There are two proteins. One is phosphatidylserine and thrombospondin. Okay, so these two proteins, again, listen carefully. I'll repeat it if you don't understand. In a normal cell, right? Let's assume there's a normal cell. Normal cell, these proteins will be on the internal aspect. Okay, it's a normal cell, they'll be inside. So can a macrophage see it? They can't see it. Obviously, it's inside, it's very well conserved, it's doing its function. Then the moment it becomes an apoptotic body, I'm reading A dot B for apoptotic body, all these proteins will come to the surface. They'll flip and they'll come to the surface, they'll come to the outside, exterior. So once it is expressed outside, the macrophage can easily find out, okay, this cell is a dead cell because they're having phosphatidylserine on the outer surface and not on the inner surface, right? So this will be in the exterior aspect of an apoptotic body. Of an apoptotic body, it will be the exterior aspect. So this can easily be picked up by the macrophage and macrophage smoothly clears them. Okay, I'm going to ask you a simple question. You must have read about apoptosis in your college as well, right? They must have taught you also about apoptosis. You must also read books for apoptosis. Apoptosis has inflammation, yes or no? Apoptosis, do they have inflammation, yes or no? They don't have inflammation, right? But can I say that macrophage is an inflammatory cell? Is that statement right? It is. Macrophage is an inflammatory cell, right? Apoptosis does not have inflammation, but macrophage is an inflammatory cell. Then why did I call it there is no inflammation, right? Have they taught you about inflammation chapter in Robbins in your college? There are 5 cardinal signs of inflammation. What is that? Have you heard this? Rubor, tumor, dolor, pallor, and loss of function. All these things. I'm great, Siddharth. How are you? Yes, right. So now the beauty of this macrophage function is they will not cause the symptoms. There'll be no rubor, there'll be no tumor, there'll be no dolor, there'll be no loss of function, right? This is very, 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 very silent, right? So this entire thing is not the routine macrophage phagocytosis. So we give a term efferocytosis. It's phagocytosis only, it's macrophage function only, but without inflammatory symptoms. So just because a cell is there, I will not call it inflammation, which means my blood has neutrophils. I won't call it inflammation in the blood. It is normally present there. Here, it is not triggered. It's not triggered. It's there. It's eating without causing the signs of inflammation. That's your rubor, tumor, dolor, all of this. Nothing will be there. It'll come silently, eat and go. That's why it's different. Though I have macrophages, I won't call them inflammation. It's just removing the debris. That's all, right? So this is what happens at the end of apoptosis, right? So in microscopy, let's assume this is a normal cell. Okay, let's compare this to this cell with a black arrow. Well, it's a normal cell. Can I say the cell with a black arrow smaller than the normal cell? Will you accept that? Definitely. Does it have a darker cytoplasm? Definitely, right? This is the nucleus of the normal cell. Can I say they with one with a black arrow is a very small and a dark blue nucleus? They do, right? So this is called as an apoptotic body. Okay. So this is an apoptotic body. It's a finding which is given in the microscopy. This is how an apoptotic body looks like, right? There are multiple places, right? So this is also an apoptotic body. It's smaller, it's darker, dark blue nucleus, right? Right. So now I'm just going to ask you a simple question. This is helpful for us to extrapolate things. Can I say apoptosis happens in the same way in my skin, CNS, liver, lung, spleen, everywhere? How do you say so? How do you think they look inflamed? Tell me what is your thought process. Let's discuss about it. It will be same, right? So apoptosis will not change from cell to cell because apoptosis is programmed. Be it in the CNS or be in the tip of the toe, apoptosis will remain the same, right? So now can I say apoptotic body will look the same across the systems? They will look the same, right? So here, what happens is when you go to systemic pathology, when you go to systemic pathology, when you go to medicine, you will start reading more of inclusion bodies, more named signs, more named symptoms. The problem is medicine is very simple. It's been complicated by human beings, right? So an apoptotic body will have the same appearance throughout the body, right? When it's caused by an acute hepatitis, in case of hepatitis, we give the term councilman bodies. Councilman is the person who first saw the apoptotic body in a yellow fever patient, right? So he said that in a patient with yellow fever, right? Yellow fever is caused by a virus. So virus will have apoptosis only, right? Any viral trigger will result in apoptosis, right? So he called that apoptotic body, he found that apoptotic body and gave it councilman body. In future, if you want to torture your juniors, discover something, give your name. Because that's the most complicated thing that can happen. If I start calling apoptosis from head to foot, only one finding, histopathology will not change. Necrosis from head to foot, only one finding, nothing will change. It's much, much, much easier, right? I have something called a disease called as lichen planus. Okay. In lichen planus, I have a condition called as civet bodies. Civet body is also an apoptotic body. Microscopy same, appearance same, everything same. But in lichen planus, I give a different term. Like this, you'll have multiple name finding, but everything will boil down to either necrosis or apoptosis. Because cell death are only two. I cannot change them, right? That's how cell deaths happen, fine? Okay. That's about apoptosis. Just a quick recap of whatever we read till now. If you want to revise apoptosis, I want you to write something like this, like your extrinsic intrinsic pathway, and that should be more than enough for us, right? For execution phase I had Cas3/6 and I had endonuclease, which resulted in phagocytosis, right? Extrinsic pathways were Fas mediated based on cell membrane. Normal cell will have Fas. When you have an infection like a virus, Fas ligand comes from a lymphocyte. They'll bind, activate FADD, cause caspase 8 or 10 activation. Intrinsic pathway, when there's a trigger like a DNA mutation, BIM bit bad will increase. They'll destroy BCL2, activate back, cytochrome C goes outside, binds to APAF, forms an apoptosome, activates caspase 9, right? So either caspase 8, 9 or 10, it will activate caspase 3 and 6, and endonuclease will shrink the cell, make them darker, and they'll make sure that the nucleus also is destroyed. Once it's destroyed, all of the proteins, phosphatidylserine and thrombosplenine flips outside, macrophage comes and eats by efferocytosis, right? Great, Siddharth, that will be great. So it's, if you make a concise note of Robbins, it's very, very, very easy to revise. And there are flowcharts in Robbins that's actually will help you a lot. The only problem with students with Robbins is, can I revise in the last? You can revise Robbins faster than any notes in the last because it's description. You read the content, revise with the description, or make a notes of yourself. That will be great for you, guys. Okay. Any doubt, do let me know. If not, we will have one more session of RRR for the first chapter by the end of this week. There's lots of classes going on, so whenever I have a Nishchay batch class, I will not be able to take RRR because of time slots, right? I don't have the books, honey. It'll be best, Sova. It'll definitely be best if you can. Okay, sorry, Sunny, I don't have the book. I'll send it across to you if I'm able to do that. Fine. Okay. Fine, guys. If you don't have a doubt, we'll call it off for today. You guys have, I want to, only one thing from you. Next 3 days, read the first chapter of Robbins. Let's revise on the 4th day in the form of MCQ so that your concepts will be consolidated. We'll revisit new concepts and then we'll seal the first chapter forever. Fine. Okay. Great, guys. See you. Bye bye. Thank you for your time.